This is Ansh Goyal from the Department of Neurosurgery at the Mayo Clinic in Rochester, Minnesota. This presentation is an overview of the chapter on benign and malignant tumors of the peripheral nerve by Ansh Goyal and Alan Belsberg. Peripheral nerve tumors are broadly divided into two categories: nerve sheath tumors that grow within the nerve and involve the outer sheath or its inner coverings, and these include benign tumors such as schwannomas, neurofibromas, perineuriomas, and malignant tumors such as malignant peripheral nerve sheath tumor, and a more recently described entity known as malignant melanotic nerve sheath tumor that arises from the spinal nerve roots and autonomic ganglia. It will be outside the scope of discussion of this chapter. Then we have non-neural sheath tumors that arise from surrounding soft tissue and secondarily involve the nerve, and these include a whole host of pathologies such as ganglion cysts, desmoid tumors, lipomas, ganglioneuromas, and so forth. In this presentation, we will talk about ganglion cysts and desmoid tumors, and the remaining types of tumors will be discussed in the chapter. Schwannomas are benign tumors that arise from Schwann cells along the course of a nerve. They are the most common peripheral nerve tumor that arise in young to middle-aged adults. They constitute 5% of all soft tissue tumors, and over 95% are sporadic. They typically present as a slow-growing, painless, firm, and round soft tissue mass. Pain and neurologic deficits may be present, but usually are inconstant unless there has been a prior biopsy or attempted removal of the tumor that injured the nerve. The mass can be moved laterally but not longitudinally to palpation, like all nerve tumors, and the Tinel sign may be present and offers a high predictive value that the tumor involves a nerve. They may arise sporadically or in association with neurocutaneous syndromes such as NF1, NF2, or schwannomatosis. The diagnosis is usually made with a combination of clinical features and imaging, as attempted biopsy of a suspected benign etiology is associated with a high risk of neurological deficit. On MRI, these lesions are typically isointense to skeletal muscle, and they are typically heterogeneously hyperintense on T2 sequences. They may demonstrate a target sign, fascicular sign, or the split fat sign, and a hypointense capsule that represents the epineurium is more commonly seen with schwannomas than with neurofibromas, and they do not show restricted diffusion and variable contrast enhancement. As shown in this publication, attempted biopsy of a suspected benign tumor is associated with a high rate of neurological deficit, and attempting a biopsy in the case of a benign tumor also increases the risk of postoperative deficits that would occur following resection. Most patients that present to the clinic with a solitary schwannoma are managed non-operatively. These tumors are often incidental findings and remain asymptomatic. The typical approach in that case would be to do a repeat physical exam and serial imaging every 6 months. Indications for surgery would include a progressive neurological deficit, severe pain, a need for tissue diagnosis, or growth on serial imaging. The steps in surgical dissection of the tumor would involve exposure of parent nerve proximal and distal to tumor, intraoperative ultrasound that may be used to aid in localization, identification of splayed fascicles over the tumor surface, and there is typically an area where fascicles are sufficiently splayed apart and dissection may begin. And it starts with development of a plane between the fascicle and the tumor, so the dissection can take place directly on the tumor surface, identification of the proximal and distal pole of the tumor, and internal neurolysis is then performed to identify the typically single entering and exiting fascicle, and stimulation of this fascicle would rarely produce a motor response. This fascicle may then be divided, and remaining fascicles may be separated from the tumor surface. The opposite pole of the tumor is then delivered by dividing the remaining entering or exiting fascicle. In some cases, because of a difficult to visualize anatomy, the tumor capsule may be opened and the tumor debulked from within. In that case, because the tumor is going to be violated, it is important to ensure that the lesion is benign and a frozen pathology specimen is sent. The tumor is then generously enucleated, which may be aided by the use of an ultrasonic aspirator, and the tumor capsule would collapse and is typically then removed. For larger schwannomas that extend well beyond the nerve, surgical resection can be more challenging and may require separating the tumor from other structures such as major blood vessels. Leaving some tumor that is adherent to major structures will increase the possibility of a recurrence from the remaining tumor or capsule. On histology, schwannomas typically demonstrate a biphasic architecture known with Antony A areas that are hyperdense and highly cellular with a compact architecture, and Antony B areas that are more loosely defined. Verroque bodies are pathognomic areas seen in histologic slides, wherein a series of elongated nuclei are lined up in a long row and usually include a palisade row adjacent to an antinuclear zone that is devoid of nuclei, as indicated by the arrow here. Neurofibromas are benign tumors that arise from Schwann cells, but unlike schwannomas, they also have additional non-neoplastic components including fibroblasts, mast cells, perineural-like cells, and residual axons. They have an intraneural growth pattern, and they're generally of two types: solitary tumors that cause a fusiform expansion of the nerve, and plexiform tumors that have multiple nodular growths along a long segment of a major nerve trunk and are typically said to have what's called a bag of worms appearance. They arise in young to middle-aged adults, and like schwannomas, they also constitute 5% of all soft tissue tumors, with 95% of these tumors being sporadic. They present in a similar fashion to schwannomas, except they're more likely to present with pain and loss of function as compared to schwannomas due to an intraneural growth pattern, and they may also be sporadic or arise in association with a neurocutaneous syndrome, such as NF1, NF2, or schwannomatosis. Malignant transformation of neurofibromas is known to occur, and there is an increased risk of malignant transformation with NF1, and the cumulative lifetime risk of developing an MPNST in a patient with NF1 is 8% to 13%. Plexiform neurofibromas almost always arise in association with NF1, and they have a higher risk of malignant transformation as compared to solitary neurofibromas, and they are a recognized precursor to MPNST. There are also premalignant neurofibromas that are sort of intermediate grade, and recently published consensus proposed the designation of atypical neurofibromatous neoplasms of uncertain biological potential for a group of tumors that would have worrisome histologic features but not clearly deserving a diagnosis of malignancy. Like schwannomas, the diagnosis is usually suspected with a combination of clinical features and imaging. Since attempted biopsy of a benign tumor can be associated with a high risk of neurological deficit. Solitary neurofibromas are actually quite indistinguishable from schwannomas on conventional MRI and generally demonstrate a lot of the similar features that we discussed before. The bottom two images demonstrate multiple plexiform neurofibromas in a 21-year-old man with a known history of NF1 who presented with multiple plexiform neurofibromas and solitary neurofibromas of the brachial plexuses and the paraspinal nerves and the intercostal nerves. And these lesions, like schwannomas, also typically do not demonstrate restricted diffusion. Indications for surgery are similar to that of schwannomas, and surgical management is also similar. It typically involves microsurgical technique to identify proximal and distal tumor poles. The fascicles on the surface of the tumor are gently elevated and protected. Unlike a schwannoma, there can be more than one entering and exiting fascicle that may need to be sacrificed with the tumor. And then consideration may be given for nerve repair with grafting in case a functioning motor fascicle is identified that needs to be sacrificed. The fascicular anatomy at both poles of the tumor is dissected out, and a large neurofibroma can often be sometimes on dissection reveal itself to be composed of multiple smaller neurofibromas that are adherent to each other. And dissection separates out the various tumors and the entering and exiting fascicles that need to be sacrificed. And surgical decision making can then actually get quite challenging and may require one to consider leaving some tumor behind rather than sacrificing function. And multiple tumors in regional or segmental NF1 make satisfactory resection of the neurofibromas without causing a significant deficit very difficult, and often only the symptomatic tumor in that case is removed. Plexiform tumors may be considered to be resected early to prevent the risk of surgery subsequently and the risk of malignant degeneration later on. And the surgical management of plexiform neurofibromas is actually quite challenging because of the difficulty to achieve a complete resection without causing a major deficit. On histology, neurofibromas have a myxomatous matrix, and have numerous collagen fibrils in the background, which leads to an intense staining with reticulin. By contrast, schwannomas do not stain as well because of the lack of such fibrils. Although the cell of origin for a neurofibroma is considered to be a Schwann cell, they are typically composed of an admixture of cells and peripheral nerve elements. And nerve fibers, highlighted by the immunohistochemical staining for neurofilaments, can arborize throughout the tumor mass, and that helps differentiate a neurofibroma from a schwannoma. Also, compared with schwannomas, they stain poorly for S100 and LU7 antigens. Atypical neurofibromatous neoplasms of uncertain biological potential are a pre-malignant stage that, in addition to the typical features of a neurofibroma, would demonstrate two of the following four features: histological atypia, loss of the typical neurofibroma architecture, hypercellularity, and increased mitotic activity. And these lesions by themselves do not represent a diagnostic entity of their own, but rather a diagnostic situation that requires further workup by additional sampling and clinical correlation to determine the definite diagnosis. Perineuromas are benign neural sheath tumors with an intraneural growth pattern and are thought to arise from perineurial cells. They typically cause a localized fusiform enlargement of the nerve. However, some cases may have diffuse nerve enlargement that may extend proximally. They typically arise in younger patients in their second to third decade of life, and they're characterized by a slow progressive motor mononeuropathy. Imaging is important for the diagnosis of these lesions, which demonstrate a fusiform nerve enlargement on MRI within the enlarged individual fascicles. Usually they have an increase in nerve caliber along the length of a nerve, followed by a gradual taper. They're usually hypointense on T1 and hyperintense on T2, and usually have avid contrast enhancement. The images here demonstrate a perineurioma of the left femoral nerve, as shown by this arrow, in an 11-year-old girl who presented with left lower extremity weakness. The left femoral nerve was asymmetrically enlarged in a fusiform fashion, as demonstrated in image C, and the normal right femoral nerve is seen here. The lesion demonstrated heterogeneous contrast enhancement and was hyperintense on T2. There's no clear consensus of management for these lesions, and surgical resection and grafting may be considered for very focal and distal lesions. However, in some cases, these lesions are found in the proximal region and they're diffuse. And that kind of presentation would be problematic for a good outcome from resection and nerve grafting. The classical histology for a perineurioma is concentric whorls of perineurial cells around nerve fibers, forming what's called pseudo-onion bulbs, as seen in image A. And these need to be differentiated from true onion bulb lesions seen in inherited and demyelinating neuropathies. And these are called pseudo-onion bulbs because they're composed of perineurial cells as opposed to Schwann cells, and for that reason they demonstrate immunopositivity for epithelial membrane antigen. Ganglion cysts are benign non-neural sheath tumors that occur when fluid escapes from either a joint capsule or bursa. The most common location is the dorsum of the hand because of synovial fluid escaping from the wrist joint, in which case the ganglion cyst may compress the median nerve or the ulnar nerve in the Guillen's canal. Other locations for ganglion cysts may include the suprascapular notch, where they may compress the suprascapular nerve, the sciatic notch around the knee forming a Baker's cyst, and the proximal tibiofibular joint. An intraneural ganglion cyst may occur if fluid tracks from the joint along an articular nerve branch. In that case, it may expand both the articular branch and the parent nerve. And it is important to identify and ligate the articular branch when treating an intraneural cyst to prevent occurrence. Typically, intraneural ganglion cysts most commonly arise around the proximal tibiofibular joint, where they may compress and enlarge the common peroneal nerve, as seen in the images to the right, which demonstrates a ganglion cyst as shown by this arrow, and that tracks along an articular branch to enlarge the common peroneal nerve. Desmoid tumors are also benign tumors, benign non-neural sheath tumors, but they're locally aggressive soft tissue tumors that grow and compress nerves, leading to neurological deficit. Surgical resection with negative margins is the mainstay of treatment, but it may be difficult to obtain margins because of their locally invasive nature. Radiotherapy may be considered in those cases where margins cannot be obtained, and chemotherapy may also play a possible role in management, with agents such as tamoxifen and imatinib mesylate being tried. The image to the right is an intraoperative photograph showing exposure of a desmoid tumor of the right anterior cervical region. The image demonstrates invasion of the surrounding soft tissues by the lesion. This brings us to a discussion of malignant peripheral nerve sheath tumors, which are rare soft tissue sarcomas of ectomesenchymal origin. They are defined as a malignant tumor arising from a peripheral nerve or showing nerve sheath differentiation, with the exception of tumors originating from the epineurium or peripheral nerve vasculature. The cell of origin has remained elusive and has not yet been conclusively identified, and it has been suggested that these tumors may have multiple lines of origin. They constitute 5% to 10% of all soft tissue sarcomas, with an incidence of 0.001% in the general population. They usually have an equal frequency in males and females, although some series have demonstrated a female preponderance. They usually occur in adults in the third to sixth decades of life. However, they may occur at a younger age in patients with NF1 than those of sporadic cases. More than 50% of these tumors arise in patients with neurofibromatosis type 1, while the remainder develop sporadically. They are very rarely known to occur from malignant degeneration of schwannomas or ganglioneuromas. Radiation is also a well-known risk factor for these tumors, and the incidence of radiation-induced MPNSTs ranges from 5% to 11% in most series in the literature. They typically present as a rapidly increasing mass with rapid onset of neurologic deficit or pain, which should immediately alert the surgeon to the possibility of a malignancy, especially in a patient with a known history of NF1, NF2, or schwannomatosis. Such a patient who presents with a tumor that shows a recent rapid increase in size, a new or progressive neurological deficit or pain, should alert the examiner to a suspected malignant degeneration. In that case, the examiner should question and record the location, quality, and radiation of the pain, the location, extent of motor weakness if present, and the location and extent of sensory deficits. A conventional MRI may be able to distinguish between neurogenic and non-neurogenic soft tissue tumors, but carries limited utility to distinguish between benign and malignant peripheral nerve sheath tumors, even when features of malignancy such as necrosis and hemorrhage are present. It has been suggested that the absence of target-signed, ill-defined margins and perilesional edema may have the highest sensitivity to distinguish between benign and malignant tumors on a conventional MRI. Diffusion-based MR neurography using diffusion-weighted imaging and diffusion tensor imaging has the potential to overcome the limitations of an anatomic MRI, owing to its ability to interrogate tissue microarchitecture. And these lesions typically do demonstrate restricted diffusion. FDG PET has also been shown to have good utility in distinguishing between benign and malignant tumors, and a recent Bayesian meta-analysis found that an SUV max of greater than or equal to 3.5 has the highest sensitivity and specificity to distinguish between benign and malignant peripheral nerve sheath tumors. The images to the right demonstrate images from a 21-year-old man with a known history of NF1 who presented to the ER with scrotal pain and was found to have multiple plexiform neurofibromas and solitary neurofibromas in the pelvis, with the dominant mass in the hemipelvic region, with heterogeneous contrast enhancement as demonstrated here, and internal necrosis and restricted diffusion. Surgical resection with negative margins is the mainstay of treatment for patients with MPNSTs, and a fine needle aspiration may be associated with a risk of disabling neuropathic pain and a potential for misdiagnosis due to the heterogeneous nature of these lesions. An open biopsy may be attempted. If the frozen section is positive for an MPNST, the incision should be closed without further manipulation, and the patient should be referred to a multidisciplinary cancer center. A wide resection of an MPNST may require excision and sacrifice of major nerves and acceptance of a possibly major neurological deficit. In most cases, limb preservation may be attempted with extremity MPNST, which has comparable survival outcomes to amputation. The images to the right demonstrate are those from a 71-year-old man who had previously undergone complete excision of what was previously read as a benign median nerve tumor in the axilla of the left arm. And within 1 year, he returned with a recurrent, fixed, and a painful mass in the same area. He was taken for surgery, the tumor was exposed, and intraoperative pathology was now identified as a malignant schwannoma that would require significant adjuvant therapy. This case underscores that a rapidly enlarging or a recurring painful non-mobile mass should alert the surgeon to the possibility of a malignancy. These are images from another case from a 34-year-old woman with a known history of NF1 who had a painful right thigh mass associated with the sciatic nerve. The patient is in the prone position in the operation. This mass ultimately proved to be benign neurofibroma, and it demonstrates that not all painful masses are going to prove to be malignant. However, there are the consequences of a missed malignancy. It is better to err on the side of caution with surgical excision of such lesions. And the MRI here is a T1 weighted post-contrast image that demonstrates heterogeneous contrast enhancement. And note that despite non-uniform enhancement of the mass, an MRI cannot predict malignancy, and this tumor was shown to be ultimately benign. Radiotherapy is also an important adjunct to surgery and may be administered in the neoadjuvant or adjuvant setting. A cumulative dose of more than 60 Gray is usually required to achieve local control, but despite improvement in local control, radiotherapy has not yet been demonstrated to improve survival in patients with MPNSTs, and these tumors are also insensitive to chemotherapy, and there are ongoing trials. On histology, MPNSTs usually are composed of spindle cells arranged in a fascicular growth pattern, and they may demonstrate perineural and intraneural spread when associated with a nerve. They are usually high-grade neoplasms that may arise in patients with neurofibroma precursor, as shown in images A and E. They also may demonstrate divergent differentiation into mesenchymal or epithelial elements. The most common heterogeneous mesenchymal element identified in MPNSTs is rhabdomyosarcoma. An epithelioid MPNST is also a rare but distinctive subset of MPNST that demonstrates, as shown in image D, large nuclei with macronucleoli. MPNSTs usually demonstrate loss of mature Schwann cell markers such as S100 and SOX10, and these may actually be even completely absent. Loss of H3K27 trimethylation is also a relatively specific feature. The prognosis for these patients is typically poor, and these lesions are the most aggressive subtype of soft tissue sarcoma. The 5-year survival ranges between 20% to 50%. The rate of postoperative recurrence is as high as 20% to 40%, and it is important to counsel patients with NF1 about the high risk of developing an MPNST and to counsel them about warning signs and symptoms such as new onset pain or neurologic deficit. A multimodality treatment approach must be developed to improve outcomes.